Good morning, it's Dr. Rutledge, and we're going to be doing a run through of Dr. Kular's presentation on the treatment of thin diabetics with surgery. So let me share my screen. Okay, good. So what if diabetes could be reversed for 6 or more years with a simple 30-minute surgical procedure, same day, much less expensive than medications and much more effective? Deadly diabetes. Is it possible? Could there be a cure? Most people say no. Diabetes, the most common cause of blindness, kidney failure, and amputation. Diabetes leads to heart disease, stroke, and damage, and diabetic complications from endocrine surgery, and a list goes on. Diabetes is a terrible disease. Here's the news. But today, we'll be talking about that yes, it can be treated with surgery. Here's a case report. This is a thin diabetic treated with an MGB, 37-year-old, 67 kilogram normal weight, BMI 25, type 2 diabetes with a hemoglobin A1C level when had surgery of 15%. So scary, dangerous. On insulin for 5 years, diagnosed with diabetes for 10 years, and underwent an uncomplicated mini gastric bypass on 3/2018. Follow up on October 2024, 6 years post-op. Stable weight, it's still 70 kilograms. That is, she lost 7 kilograms. But her hemoglobin A1C on follow-up, 6 years later, 4.7. Normal. Normal triglycerides, which were elevated. No recurrence of diabetes and no complications. Improved quality of life, resolution of sleep apnea, migraine, breathlessness on exertion. This is not a fluke. We'll talk about that today. What if we could resolve diabetes? You can call it a cure or not call it a cure. You can call it reversal, whatever you want. This person, 6 years, no diabetes. 6 years, normal hemoglobin A1C instead of a progressively elevating hemoglobin A1C from 15% on insulin. Imagine, it's here. This is Dr. Kular speaking, a modest proposal that the MGB, and particularly the MGB2, is a treatment that can reverse. Maybe we're not allowed to say cure, but you can be without diabetes for decades. I don't know what you call that, but it seems like it's good. The report comes from Dr. Kular, Dr. Machenda, and Dr. Rutledge. It's the first report of successful long-term surgical treatment for diabetes. And we're going to talk to you today about 52 patients who have 7-year follow-up. Just listen to this. The preoperative hemoglobin A1C was 12.6. That's in the deadly zone. And postoperatively, at 7 years post-op, the mean hemoglobin A1C was 6.1. What we know now, we now know that the MGB, and particularly the MGB2, can completely reverse severe diabetes for more than 5 years and routinely off all medications. What we have to present to you tonight is absolutely revolutionary. 10% of India has diabetes, and many are being treated with medications with inadequate control. We have the solution. India is in a deadly diabetic pandemic. Drugs only change the hemoglobin A1C by 1% on average, even with the best studies, with the best treatment. For 100 years, the Bilirubin-2 has been successfully improving or treating diabetes. The MGB2 can treat thin diabetics. That's what Kular's data shows. And the MGB can treat thin diabetics. The future is also a simpler and easier operation, the MGB2. Well, we won't spend too much time because we're busy, but India is in the midst of a deadly pandemic. And we're going to talk about diabetics and their treatment over the past several years. 77 million, one of the world's highest rates of diabetes, which weighs on the humans, the people, the government, all of us are suffering. But medications only result in a change in hemoglobin A1C of average of only 1%. They do not cure. They do not reverse. They do not often help the suffering diabetic. What if we could? Now, I won't go into this tonight, but basically for 100 years, the Billroth-2 in animal studies and in human studies have been shown to successfully improve or resolve diabetes. The MGB and the MGB2 are nothing more than Billroth-2. PubMed has, I say, over 100 articles. It improves or reverses diabetes. In Kular Hospital, 55 thin diabetics, followed for 7 years, underwent a mini gastric bypass, a well-known, widely accepted surgical procedure with some modifications. The preoperative hemoglobin A1C, as I showed you at the beginning, has decreased on average 7 years later to 6.1. Hemoglobin A1C from abnormal and deadly to normal. Here's the graph. Preoperatively, average was 12.6, and look, 6.7, even up to 6 and 7 years post-op, the hemoglobin A1C was still steadily improving, not worsening. Again, 6 years, 6.1. I didn't show the 7 years because there's a few fewer patients in that group, but the numbers are the same. Look at this. This is death, disease, amputation, blindness, and this is no medications. Look at the power of the MGB in thin diabetics at 7 years. Here is the range below 7. 94, 95% have a hemoglobin A1C less than 7. Only 5.4% had one greater than or equal to 7. This is not magic, but it's right next door to magic. This is a long, healthy life, and this is death. And we improve even the patients who don't come down because they are much better than what they had. Pancreatic failure, beta cell failure, C-peptide failure. Listen, the low peptides, when we measure them, low C-peptide indicates pancreatic failure. The insulin-producing beta cells are no longer producing insulin. It indicates severe disease and beta cell dysfunction and often beta cell death. It also leads to a higher hemoglobin A1C. And a low C-peptide level indicates pancreatic fatigue or even death, and diabetes is worse, and sometimes the complications are worse as well. When to operate? We think the following data shows the answer to that is early, before the pancreatic beta cells are inexorably and completely damaged, before there's progressive organ damage like blindness and heart attack. Operate early on these patients because the operation is almost trivial. It's essentially performing a gastrojejunostomy, and that's it. Not after someone is blind, not after someone has dead gangrenous foot, not after someone has renal failure, and not after stroke or myocardial infarction. Here's a hemoglobin A1C levels and related to the C-reactive protein. At 7 years, look at the average hemoglobin A1C. This is normal. This is normal. Now, if there is no C-peptide, then we can't make them normal. Okay, what we need is the pancreas to come back to work. If you have pancreas, it looks like we can cure, improve, reverse diabetes. But if you have no C-peptide, then the opportunity to save a life may be lost. Same graph here. So normal C-peptides above 0.5 and pre-op C-peptide predicts surgical success. Low C-peptide, these are dying cells that make insulin. Without them, you're doomed even with the surgery. Now, the surgery makes them better by far, but this is the opportunity zone. That's everyone else here. Operate on them because these numbers are life-saving. Before damage and loss of pancreatic cells, before this happens, this is where we want is the zone where we can offer the probability of cure. Can't say cure for sure yet. We don't have 100 years of data. But in the 7 years, look at these hemoglobin A1Cs off medications. Also, we know age. So operating early is better than operating late. Even though you have these good results, we can have better if we operate earlier. Now, we did choose the biliopancreatic limb length based on the weight of the patient. That's important in the management of large obese patients, but there was no statistically significant in the effect of the operation based on BP limb length. So you can simply make a short BP limb, about 100 to 150 centimeters, and in most cases, diabetes will resolve. Okay, now it turns out that Dr. Kular and Dr. Magenda did tailor the BP limb to the weight. And they found that when they did that, it didn't make any difference. So this is the R squared is 0.05. So there's no relationship between the success, that is the hemoglobin A1C at 7 years, and the BP limb length. BP limb length does not improve outcomes for those who are MGB skilled surgeons. No association of BMI with delta hemoglobin A1C. Now, what about albumin levels? Well, what we know is there is fear of bypasses and things like that. But what our data showed is that only 2 people, one had borderline low and one had low albumin level. But for the vast majority, they did well. But the one who did have some problems had a longer bypass. So in general, we would say for thin diabetics, you want to make a short or somewhat shorter bypass, and 190, 195, 200 might be a bit long. No association between BMI and pre-op hemoglobin A1C level. So weight and BMI in this subgroup is not significant. And when we said again, when we look at the BP limb length that was performed by the surgeons, it doesn't make any difference. It's just all over the place. No patient less than 200, no evidence of MGB malnutrition. So this is the BP B12. And so B12 is not associated with the bypass. And so people are frightened about a bypass in an older patient or a diabetic patient, but there was no one who had a B12 level less than 200 in this series. And so this is the same graph. Basically, nobody was less than 200. Everybody has it above that. And this is a trend line for 7 and then preoperatively. So pre-op and post-op, everybody had basically normal B12 levels as a measure of absorption and outcome. Everyone post-op lost a little bit of weight, but almost everybody is perfect. In other words, remarkably, a short bypass and treatment of diabetes leads to a normal, healthy weight and usually a normal, healthy person. So, success. In summary, knowledge and experience with the MGB led to adequate success selection criteria, and the treatment of young, moderately severe, thin diabetics led to 5-year success in 95% of patients. Imagine 95% of diabetics no longer diabetic. We now know that the MGB and the MGB2 in particular can completely reverse severe diabetes for more than 5 years and routinely off all medications. What we know now, the MGB and MGB2 can completely reverse severe diabetes for more than 5 years, off and all medications. The future, MGB2. Thank you all very much.